Thank you for the opportunity to take part in this important program. I was thrilled with the discussion during the first workshop. It hit on so many of the issues that we also have here in America. Nairi asked me to speak to the group from a client perspective on why it matters that solutions be found. I'll move quickly and try to keep it brief, but please bear with me because the details are relevant. You see, my dog Lightning was a poster child for unregulated research and overtreatment. Just to give you a bit of background on my professional experience, in the early 1990s while I was a pharmacy student, my first job in medicine was at Duke, where I worked as both a pharmacy technician and research aide for the largest global clinical trial of its time, a landmark study that was credited for assuring patient safety and avoiding conflicting interests. I then took a job as a clinical staff pharmacist at Duke, where my focus on patient safety continued. During that time, I was appointed as a peer reviewer of a widely publicized medical error tragedy at a different hospital that became a sentinel event for improving national patient safety standards. After pursuing a postgraduate degree and completing a specialty residency, I took a job at another leading research hospital. I was involved in research at both IRB and patient care levels. When we discussed clinical trials with patients and their caregivers, we had multiple parties involved: the physician, the clinic nurse, myself a pharmacist, an independent research nurse, a scheduler, and more. We spent hours and repeated visits discussing and providing written materials for review before patients consented to participation. After that, I worked in the pharmaceutical industry in various capacities, including medical communications, drug safety, and research liaison. Compliance was of the utmost priority, with legal, regulatory, and ethical standards underpinning my career. Fast forward to 2013, when Lightning, at 2 years of age, was diagnosed with orthopedic disease and began to undergo a series of surgeries at a well-respected private specialty practice. His initial diagnoses included bilateral hip dysplasia and left medial patellar luxation. He underwent a right total hip replacement with a plan to follow with a left hip replacement and treatment of his medial patellar luxation at the same time, but that changed after he developed an almost imperceptible new lameness on the right hind limb a few months later. The hip specialist referred us to a colleague who specialized in knees. The knee specialist diagnosed bilateral cruciate tears, and he recommended treatment with minimally invasive arthroscopic cruciate repairs that he said he averaged 15 times per week, starting on the right side. My husband had just had a cruciate repair, and I understood what the veterinary specialist was proposing to be similar in nature. I also found a local news story about this specialty practice saying that it performed more cruciate surgeries than anywhere else in the country and emphasizing the arthroscopic technique. In fact, it specifically said the operation is almost exactly like the one for people. I was provided no written materials other than this one-page authorization and release, and I was told the specialist just so happened to have an opening in his busy schedule 36 hours later. I remember being overwhelmed by this abrupt change in plan, but assured by the specialist's words and the confirmatory news story. In my distressed state and wanting to help Lightning, I hastily signed on the dotted line, regrettably overlooking the text below right stifle arthroscopy. Lightning was discharged by a technician on a Saturday. We didn't see the specialist or the x-rays. It quickly became clear, based on Lightning's apparent pain and the incision revealed after the bandage fell off, that he had not had a minimally invasive arthroscopic cruciate repair. When I questioned it, the technician spoke to the plate and screws that had been used, causing me to begin researching. My dog's tibia had been cut and put back together with implants, and I did not understand this until after the fact. I learned through my research that the specialist taught TPLO courses, TPLO standing for tibial plateau leveling osteotomy, the bone-cutting cruciate surgical procedure used for decades. And of course, when I look back to the authorization, it said tibial plateau osteotomy, CBLO/TPLO. This was in 2013, before anything was published about CBLO, so at this point I assumed CBLO must have been a minimally invasive form of TPLO. Still, I did not press for answers or ask to see the x-rays as I should have. Lightning had a number of clinical problems, which I felt kept being marginalized or referred back to his general practitioner. I attributed the continued challenges with communication to a bad fit, so stopped seeing the specialist and transferred Lightning's care to the State College of Veterinary Medicine. There they focused on Lightning's left knee, but also referred to an historical right TPLO in their radiology reports and notes, supporting the notion that a TPLO had been performed at the private specialty practice 9 months prior. At the university, he had a TPLO and treatment of his medial patellar luxation, first with trochlear wedge recession, and then with tibial tuberosity transposition. When the doctor showed me these x-rays, I joked that it was his Frankenstein knee. I still hadn't seen x-rays of his right knee treated at the other facility. Lightning continued to have orthopedic problems, but after 4 bone-cutting surgeries in 14 months, we stopped seeing orthopedic specialists altogether due to the burden on him and on our family. This just didn't seem to be helping, and it certainly seemed to be hurting. His general practitioner did her best to manage his pain, and we even saw a behavioral specialist because Lightning had become aggressive. In January of 2016, his right knee seemed to be worsening. To be clear, he was never without problems after his right cruciate surgery, but we had long reasoned that it must be the weather or another joint or something else because that knee had been treated by the best. The first week of February, Lightning went abruptly and severely lame on the right hind, and his general practitioner took x-rays. This is what was revealed. Neither his general practitioner nor the radiologist could explain. We tried to get Lightning back into the university, but it was a 2-month wait. So we had to return to the right cruciate surgeon. This time I brought my husband with me because I needed a second set of eyes and ears. The surgeon claimed the implants were normal and pointed the finger elsewhere. He recommended a 2-week course of at-home physical therapy and a new omega-3 fatty acid supplement. We left disappointed, knowing that would never cure his ails, and resigned to the fact that it was time to begin the euthanasia discussion with our young sons. But first we sought a second opinion from another specialist we were able to get in to see. That surgeon suspected a late meniscal tear and recommended treatment of the meniscal tear and removal of the implants while in there, which he thought might bring relief. He couldn't explain why a CBLO had been performed on Lightning in 2013. He still didn't use the new procedure 2.5 years later. He suggested we return to the index surgeon, but we decided to use him instead. Lightning's meniscus was indeed torn, but his early partial cruciate tear had also progressed to a complete cruciate tear, meaning the bone-cutting surgery that had caused him so many problems since 2013 did not do its job in stabilizing his knee. Unfortunately, the diagonal screw in question was left in place because it was thought that it might cause greater morbidity to remove it than to leave it in. I later learned it was a human headless compression screw with a bone-cutting tip meant to reside inside the bone that was indeed challenging to remove. It was added to CBLO because CBLO turned out to be much more unstable than TPLO due to differences in the surgical procedures leading to different biomechanics. Thoroughly confused by all that had transpired, I obtained a copy of Lightning's medical record from the original specialty practice and set out to find answers. A TPLO study was referenced, and TPLO and CBLO were used interchangeably in the chart. What was CBLO, and why was my dog used for a study? I didn't consent to a study. After 2.5 years of challenges, I was finally beginning to understand that Lightning had undergone a Cora-based leveling osteotomy, a new type of bone-cutting cruciate surgery that was being researched and developed principally in private practice patients without research protections, in my case, including truly informed consent. I also retroactively obtained copies of Lightning's x-rays. Here you can see the difference between his right CBLO in 2013 and his left TPLO in 2014. I'll start with TPLO because it is the more conventional procedure, although still a far cry from the minimally invasive arthroscopic graft procedures used in humans. The top of the tibia is cut from about 12 o'clock to about 3 o'clock and rotated backward. This alters the architecture of the joint to stabilize the knee and make the cruciate ligament redundant. With CBLO, the tibia is cut all the way through and rotated forward, clearly substantively different from TPLO, although a TPLO plate and human headless compression screw were used for Lightning's CBLO because CBLO-specific implants had not yet been developed. After the 5th and final surgery in February of 2016, Lightning continued to decline and we humanely released him 9 months later. On my quest for mitigating the risk of similar misfortunes occurring to others, I dialogued with untold veterinary professionals and representatives from these organizations and more. The overwhelming majority were sympathetic and directed me back to my state veterinary board, the only organization that ostensibly regulates veterinary health care. Our state veterinary boards in the U.S. are the equivalent of your RCVS in the UK, and our ACVS is a specialty surgery college more akin to your ECVS. Unfortunately, my state's veterinary board doesn't even have a statute or rule mandating informed consent for any treatments, except select alternative interventions such as homeopathy. 6 years later, I am still dialoguing and still trying to facilitate change. While I realize that things are different in the US versus the UK, I feel like they are more similar than not. Early in my crusade, I found an article by Tori Hampshire written when she was the Director of Advanced Veterinary Applications at the US FDA. It underlined my concerns about a gap in companion animal research protections, but it was written in 2003, and I figured things surely must have evolved for the better in the intervening years. Then I came across a more recent piece written by Eddie Clutton and colleagues. It also underlined my concerns, albeit in the UK. I wrote to Eddie applauding their letter, and they warmly welcomed me to the group that was later formalized as Ethics First. As we worked on various endeavors across the Atlantic, I continued to search for answers in the US. I confirm the research gap indeed still persists here. Some have tried to address it through best practice recommendations. And while I appreciate these best practices, they are not upheld in law. In my country, as in yours, federal laws protect human and laboratory, but not necessarily companion animal research subjects. Academic centers thankfully have review systems, even if imperfect, in place. Private veterinary practices where most patients are seen may not and aren't required to by law. And standard of care, or recognized veterinary practice, as we know, is often subject to debate. In 2018, I wrote a letter to the editor of the JAVMA about just that. In these papers, written in 2018 as well, we focus on the research oversight gap where devices are concerned, but it also applies to extra-label use of medicines, biologics such as stem cells and PRP, radiotherapies, and more. I should note that in the US, it seems some assign creative designations to new interventions to avoid regulatory oversight. This lack of regulation, combined with subjective standard of care, or recognized veterinary practice, creates a loophole which enables unproven treatments to be introduced into client-owned animals without safeguards in place. Some other contributing factors I have observed are that regulators tend to be lenient, particularly when it comes to advanced veterinary care, which can be perceived as a higher than standard of care. Innovative, new gold standard, cutting edge, novel, and other such terms are often used to favorably describe interventions that lack substantive evidence. This can lead to caregiver enthusiasm and undue influence. A number of conflicts of interest can also come into play, with veterinary professionals, marketing authorization holders, owners, media coverage, and more, making independent ethical review and proper study conduct essential. As if all of this weren't concerning enough, some of these unsubstantiated interventions are seeded to the masses through short continuing education courses, many marketed as certification courses. These involve no audit, no quality assurance, no formal post-marketing surveillance. This means that treatments can be used for years, potentially by the non-proficient, putting animals in harm's way before medical reversal occurs, if it even does. But this is another topic for another time. Retrospective case series are also problematic, as patients are prospectively treated with experimental interventions without research protections in place and then selected for publication. I'd like to close with some opportunities that could be pursued. The interventions about which we are speaking are generally elective. In many of these cases, the idea is conceived during an initial consult and it takes time to schedule treatment, whether due to veterinary surgeon availability, instrumentation, material acquisition, etc. As discussed during the first workshop, it seems independent clinical and ethical review could be undertaken in parallel. Informed consent, by my view, should be more than commitment for payment and legal release, not just, but especially for research use of client-owned animals. And ideally, a third party would administer it, but at a minimum, it should include multiple parties, multiple conversations, and provision of written or electronic materials. When Lightning was treated at the university, they asked if he could participate in a clinical trial to evaluate bone length, simply measuring his bones while he was under sedation for x-rays. After a thorough discussion and reviewing the 4-page consent form, 4 pages for something they could have in theory done without my permission, I agreed. Contrast this to my consent experience at the private specialty practice for what was unquestionably an experimental intervention. To be clear, at no point during Lightning's clinical course would I have agreed to anything but tried and true treatments considering all of his orthopedic problems. Clients who it may seem unreasonably pursue treatment at all costs, including to their animals, may actually be unwittingly caught up in the madness. Most trust whatever is being recommended and don't think or know to question the experts. Caregiver placebo effect applies to both owners and veterinary professionals. Veterinary professionals and I chased treatments for years, not understanding the investigational nature and failure of Lightning's right cruciate surgery from nearly the start. We subjected him to a lifetime of overtreatment, including surgical. I should note that if problems arise with innovative treatments, it can be difficult to find another vet to intervene. This is not only due to the typically greater cost, but also due to complications that can't be explained or addressed by anyone other than the pioneer. Some clients are also subject to non-disclosure agreements. And of course, caregiver burden can be tremendous. I'm not certain how this would be accomplished, but caregivers, specialty practices, manufacturers, insurance companies, the media, and crowdfunding vendors should also be held more accountable. Fortunately, evidence-based veterinary medicine, standard of care, or recognized veterinary practice, informed owner consent, and ethical study conduct are among areas with recent calls to action. A number of participants of this webinar have worked tirelessly for years to help mitigate harms from unregulated research. The RCVS Ethics Review Panel is a terrific step forward, but it is not mandatory and can therefore be circumvented, which is why it is important that other solutions be found. All of this is meant to say thank you for your efforts to put lawful protective measures in place for pets and all of their caregivers. I, for one, am immensely grateful and hopeful that the UK may serve as a model for the US. Thank you.